Hi, greetings and warm welcome to Chapter 5 of Spectacle Options for Myopia Progression in Children. Now, I think this is something which has come up very recently, at least in Indian market. I think the glasses starting from Hoya's, DIMS and Stilest introduced their halt. And then I think Zeiss came up with their Care lenses. This came in around 2020-21, and the main prohibitive factor at this point of time, yes, is cost. But I think more and more patients, more and more doctors, more and more ophthalmologists and pediatric ophthalmologists are now thinking about myopia progression also in terms of glasses. The glasses are now gradually getting recognition that they hold a place in the management. And I think a lot of interest in myopia has also originated from the fact that you or at least have an alternative to atropine. So now we have spectacle options for myopia. And at this point of time, to understand that more and more options would be coming also in pharmacological treatment and even in the type of glasses, we would see what are current available glasses in the market and what is the future, and there would be more and more type of glasses which may come in future, depending on what are the theories and what is the constant change in the thought process of how myopia is progressing. The underlying term always is about reducing the myopia progression and not truly treating the myopia. So that was regarding understanding regarding the introduction of myopia being treated with spectacles. I think before we talk about what are the glasses which are available and what is the cost and how to prescribe and who could be useful here, what is the way of doing it, we should first try to understand what brought spectacles back into whole of this stuff. Because if you read old articles, there was some interest in bifocals and peripheral add-on lenses, PAL lenses, progressive lenses, where they tried to show, especially the comet studies way back in 2000 and 2005, where they were trying to show that if you add some power for near, there is a chance that myopia may not progress, although they were not very effective. But nevertheless, at least some studies did show that there was some control in glass progression. So before we move on to the actual thought process of which glasses are available, we should try to see what happened and why all of this is important. So at this point of time, what is known? What is known is we have already talked beyond genetics. We have talked about little bit about what is genetics, and we have talked about biological mechanisms of atropine control of myopia. We have talked about how atropine releases dopamine, how it affects GABAergic receptors. We have talked about how atropine is a non-selective muscarinic antagonist, and how it is useful at the level of retina, at the level of sclera, at the level of choroid, and how it affects, and how choroid is also an important factor when it comes to myopia progression, and how it sort of accommodates. And as the choroid gets thinner and thinner, the eyeball size sort of increases, and it is giving a way to retina to come posteriorly and and the eyeball size increases. Now, another theory which came up, I think starting from 2006, 2007, and was built up over a period of time, especially from Houston, Texas, the group of Earl Smith 3, was on peripheral hyperopic defocus. And the third theory, which is also becoming more and more popular with the dot spectacles of Essilor, is on high contrast stimulating bipolar cells, which are part of the retinal layers. So when both the center cones and the surround are covered by uniform illumination, there is no response to contrast. More light is on the center cone than the average of surrounding cones. So there is a central cone, and then there are surrounding cones. The on bipolar cell is activated and signals light against a dark background contrast. And then the third thing is when more light is on the average of surrounding cones than on the central cone, the off bipolar cell is activated and signals dark against a light background contrast. And this is what is also related with the axial length progression. This is the signal on and off bipolar cells. They induce a signal process and they send back the biofeedback, which starts the cascade of axial length growth. So we will see mainly peripheral hyperopic deep focus and high contrast stimulating bipolar cells. We've already talked about atropine in the last talk. Now, how does peripheral refraction influence eyes? Now this is very interesting. So what was done was that Earl Smith 3 and the group of co-workers, which includes the famous pediatric ophthalmologist David Coates from Houston, University of Houston, what they did was they ablated the fovea of 12 rhesus monkeys, infant rhesus monkeys, and they tried to find out whether the eyeball size still was growing. And yes, to their surprise, the eyeball size continued to grow despite foveal ablation. Now, coming back to the original theories, we always have understood that the eyeball size increases secondary to the foveal blur or secondary to the image that is visible on fovea. But there is no big thought process on what happens with the area surrounding the fovea. So once the fovea is ablated, it was thought that it was indeed the peripheral area of the fovea or perifoveal area or paramacular area which was responsible for the eyeball growth. And then there was a series of articles where they saw relative peripheral hyperopic defocus. So once they found out that it is this particular peripheral area which is responsible for the growth of eyeball, they tried to defocus the images in the periphery. And they created a peripheral hyperopic defocus with the help of optical defocus was created. And then there were multiple articles in which they tried to see what happens with optical defocus on the refractive development in monkeys. And they found that once you impose an optical defocus, it can alter the shape and pattern of peripheral refraction in infant primates. Now this is all done on rhesus monkeys, which may mimic humans, but it is not truly done on humans, at least at this point of time in 2010. And then they followed it up and did some studies on optically imposed defocus in adults. But at this point of time, they tried to see what happens when you alter the central refractive development by relatively increasing the hyperopic defocus. So you can see that this is the treated eye and this is the control eye. See the curvature of the control eye versus the curvature of the treated eye. This particular part definitely is, once you superimpose these two things, you can see that the temporal part has grown much more compared to the nasal part, because this particular eye was the treated eye. They altered the temporal part, they altered the temporal defocus, which means that image was not, see the image is on the fovea, the image was not forming on the peripheral retina. In fact, it was optically altered and it was focusing behind the retina. And so the eyeball tried to catch up, and they tried to do it differently for temporal and nasal retina so that they can actually see whether this particular peripheral hyperopic defocus which has been induced optically is making a difference or not. So this is the corrective lens, this is the DIMS lens. This is correcting the peripheral hyperopic defocus and making it myopic. So this is what is the theory behind peripheral hyperopic defocus inducing the growth of eyeball. Now we come to another point which is known as peripheral refraction. What exactly is peripheral refraction? What do we mean? What do we understand by peripheral refraction? So peripheral refraction is when you do a central refraction and then move on to do the peripheral refraction of the nasal off axis refraction, which means you are doing nasal refraction and temporal refraction either by telling the patient to move the eye or by moving the machine. Now here is where an open field autorefractor, which comes with a transparent screen. This is an open field autorefractor. There's a transparent screen you can move the transparent screen, you can bring it closer to the eye. And originally this was designed mainly to see how much patient is able to accommodate. So you can bring this particular chart from distance to center, and you can actually measure the amplitude of accommodation, because the readings will keep on changing. The moment you show a patient a distant object versus you show a near object, he will accommodate. And what is the actual accommodation which is taking place, an open field autorefractor can tell you. But you can easily ask the patient to look at 10 degrees temporal or 10 degrees on the right side, and then you can measure the temporal refraction of right eye and nasal refraction of left eye if he is looking on 10 degrees to the patient's right side. And similarly, you can ask the patient to look on the temporal side, left side of the patient, and you can measure the peripheral refraction similarly. You can do it at a difference of 5 degrees. You can do it at a distance of 10 degrees. But you can see what is the peripheral refraction, how much is significant. Any reading beyond plus 0.5 to plus 0.75 is said to be significant, and we will see that there is the multiple studies have no clue, no idea how much of a blur is significant, how much of a periphery is also significant. But right now the present thought process is that if there is a blur of around plus 0.5, that is significant enough to induce myopic changes. Now, how do you do it if you don't have an open field autorefractor, which is also an expensive device? uh, we designed our own solution for that, and what we did was we tried to make two arms in such a way that they can be put on a holder. And the theory is that if the patient is sitting here and you are using a 67 centimeter, if the length of the arm is 24 centimeter, you are measuring around 20 to 25 degrees. If you go closer, you may be measuring even higher periphery, and if you have a distance of 1 meter, it will collapse down to almost 18 degrees. So nevertheless, you are still measuring at around 18 to 20 degrees, which is significantly peripheral, at least for the myopia progression or not. So this was the initial device that I had thought and drawn with my hand initially, and this was the first device. This was the first prototype which we made. This was a simple prototype which we made, and it was difficult to put it here. It was very difficult, but it was very sleek in the sense that it was easy to put. The problem was that this is the patient. You can see the patient is moving head. We will see into that also. But right now he's looking on the left side, and what you are doing, you are measuring the nasal refraction of right eye and temporal refraction of left eye. You are giving a target here. Now, gradually we talked with the industry, and gradually we modified this particular equipment, and we came to this final equipment where you have a holder here, because this is the initial holder that we had thought. And this holder you can put inside you can fix it on the retinoscope. There is a screw here. You can use that screw to tighten it, because it all depends on what is the thickness of the handle of this particular retinoscope, and accordingly you can fit it there. I do understand that this is quite bulky, so we separated these two arms, so that we can easily do it. So these are detachable arms. We don't have to put it every day, but we tried to find out that to achieve a good peripheral refraction, we have to make at least 24 to 25 centimeters. So this is the final thing. There are LED fitted, and you can ask the patient to look on the particular LED which is on, and then you can ask the patient to stop looking there, and you switch on the second LED. So this is how at this point of time we are doing peripheral refraction our clinic. I can show you another video in which we have used this particular device mainly to we have used two videos here. One is from the top view, and right now we are asking him to look on this particular side. See, we are asking him to look on his left side, and we are recording the refraction. It is pretty simple actually. Once you tell the patient to look on this particular side, and if you get a width reading, suppose if you are getting a width reading, this patient doesn't have glasses, but if he have glasses, you tell him to use his glasses and try to look on the peripheral side. Now, once you have a width reading, it means at least a zero point 0.5 refraction is there, and that is also significant. For the research purpose, you can always note that down and see whether it changes or not, and whether once you give him glasses, whether that particular peripheral refraction is being changed into peripheral myopic refraction or not. We have done it. It works, but you can always calculate, and I will show what we did some study and found out how much was the peripheral refraction, at least in Indian eyes. Now, there is always a concern when we talk about peripheral refraction measurements. Does it matter if one turns the eye or he turns the head? Now, what has been suggested is, and what has been thought about is that the forces exerted on the eyeball when you look in the periphery can alter peripheral refraction, but at least a couple of studies do suggest that that is not the case when you try to, at least in the horizontal axis, and you can see that in J180 the dioptric change is minimal, and with high turn versus head turn, eye turn versus head turn, there was hardly any change in the refraction. So that rests all about the peripheral refraction. Now coming to the glasses, there are at this point of time in India there are three particular companies which are available. One is DIMS, which is Defocus Incorporated Multiple Segments. What they have is a clear central 9 mm zone and lenslets of 1.03 millimeters. This particular thing is a fixed amount of power which is there. They can make up to 10 diopters of minus power and a cylinder of 4 diopters, meaning if you have 6 and 4, that is the maximum. It doesn't go as spherical equivalent. It is straightforward additive. So if you have 7 sphere, you can only give 3 diopters in cylinder. The cost at this point of time is 15,000 to the patient, but they do give offers, and up to 25% they do reduce. Most of the times the offer is on, and this is cost to the patient. To the doctor, it is around around 8,800 or 9,000, and MRP is I think it has been revised to 15,800 or something, but roundabout that is the cost, and they give 25% off on that. This is a polycarbonate glass. Another important advantage of Hoya is that they do give you I think they do give photochromatic lenses also with this, which is not there with Zeiss and with Essilor. The only thing is that these are all fixed power lenslets, that is plus 3.5, and otherwise it works. Similar design, similar concept, but different design. They have multiple rings, so there is an array of multiple rings with different powers, and the power is not known. It is a patented product. So what they say is that as you go into periphery, the focus changes, and it is actually the volume of myopic defocus which it creates. So it creates a different amount of myopic focus defocus as it goes into periphery. The power is same, but now they have upgraded it to up to 12 diopters. So you can have it 8 and 4 or 10 and 2 or minus 12. So that is the maximum that Essilor provides. They do give it in different tints, but not the photochromatic one. The cost is almost comparable, and everything else is comparable. Marketing, everything is same. The cost 25%. They also give discounts. Sometimes they have offers of the buy one get one type of offers. So that all is there with your optical shop. But you should be aware of what is the cost, because patients do ask you directly as to which one is good and what is the cost. And this is Zeiss Myovision Pro, the Care, which has a very similar design, except that the cylindrical annular refractive elements, they call it Care, and the previous one, Halt, is highly aspheric lenslet design. So that is the Essilor one. Care is cylindrical annular refractive elements. So these are the refractive elements with a mean additional power of between 3.5 to 4.5, and that creates a myopic defocus problem. Few small issues. They have two designs of central zone 7 millimeter and 9 millimeter for lesser power, higher power. Same principle, almost same design, except that their elements are as per them, they are better placed and behind the lens and not in the front. But all of them functional zone are, so they do say that it is much easier to adapt, and all the three companies are comparable. The only advantage between three companies is that with Zeiss Care, you can get the lens at 8,000 if the power is less than 6. If the power is more than 6, then all three are same. Zeiss does not give discount above between 6 to 10 powers, but they do give at 50% when the cost is when the power is less than 6. 6 is additive, 4 plus 2. So you can have maximum of 2 cylinder, but if the maximum of 2 cylinder is there, then you can have a maximum power of only 4. Spherical, you can go up to 6. So that is how, that is the difference of Zeiss. The fill factor is 0.5 diopters. Now, this particular lens was very much into vogue when nothing else was working. A lot of articles were there where they said that the peripheral distortion and the PAL lenses, peripheral add-on lenses work. There were multiple studies which suggested that near add also works. At this point of time, there is hardly any evidence that it works. Where do I use it? I use it when we are using a higher concentration of atropine, when I am switching the patient from 0.01 to 0.05 or even higher than that. I will definitely think of adding this particular lens, because it makes things easy for the patient when he's trying to look for near. That is at this point of time the work of this particular lens for me. Now, what is the experience with DIMS, with Halt, with Zeiss, all these lenses? It is very important to discuss and talk about what are the experience profile from various countries, especially from the countries where it was released first, and what are the results, at least in Indian population. All these three studies that you see, some of the authors like Lam or Hua QE, and I think some of them Wing Chun Tang, all these authors are, if you read their profile, they are from company. So yes, there are some people who are authors and they have written the paper, and they are on the employee list of company. But all the multiple studies do suggest that DIMS, Halt, everything works. They have compared highly aspheric lenslet technique with defocus incorporated multiple segment spectacle lenses, and bulk of the work at this point of time is on these two papers. One is the DIMS and one is the Halt. So this I would suggest is a very wonderful article on what are the characterization between the two. Now, if you see here, what are the morphological characteristics of these two myopia control lenses? Now here, if you see, you have got a radius of around 4.5 here with a 9 millimeter as suggested by them. Here you have a radius of actual radius of 5 millimeters. So this has a bigger area in the center. There are 11 rings, whereas here there are only 9 hexagons. The distance between the two lenslets is hardly anything. Here you can see there is some distance and an angle of around 60 degrees. So if you see the difference between the uh, design per se, yes, Halt's appears to be technically better than DIMS. Clinically, this is a head-to-head study. There are multiple studies, Lam et al., Bao et al., and another study which I am showing, this particular study, DIMS study, Hall study. They have compared both studies, DIMS versus single vision, Hall versus single vision, and it is almost comparable. Both the things are working. So it is basically the principle of peripheral defocus that is what is working between DIMS and Halt, Hoya and Essilor. And our experience with the spectacle control in last couple of years. So we started off with bulk of our patients were on DIMS, and then we switched over to Halt, and then care mainly for lower powers, because the powers were low, because they're cheaper compared to Halt and DIMS. Follow-up, obviously, since we started with DIMS, the follow-up is more, and with Halt, the follow-up is little less compared to DIMS. But all three of them have worked better for us. The only thing is that these two lenses, we have used it for almost 2 diopters to 10 diopters, whereas for care we have only used them up to 5 to 6 diopters. So obviously the progression is more in these particular children who start very early. But progression before Halt, progression before DIMS, if you see, the refraction was increasing per year at 0.81 diopter, at a mean refraction of 0.81 diopter, and here it was 0.91 diopter, whereas in these patients it was 0.78 diopters. But it was a very good control with DIMS per year. Halt definitely showed slightly better, but if you see the statistical significance, it was almost same in both. The control, the progression was 0.26, but the original refraction was also increasing at a lower rate for these care patients. So if you compare them statistically, all three of them work, but clinically at this point of time, Halt is slightly better than DIMS, but both of them work very nicely. I think this particular difference may be for one particular patient that is skewing the whole data, but otherwise it is working fine. All three of them work, but mainly it is DIMS and Halt which we are using, mainly because these were the early in the market, and now care is also picking up. So once we see that they are working, once we see that the results are comparable for these glasses, now whether they can be used as a primary therapy. So if primary therapy means if the patient comes to you for the first time and you see that he is progressing, whether we can start glasses as a primary therapy. Now the cost involved is definitely higher compared to low concentration atropine, where the cost is not much, but the compliance is very good with glasses compared with atropine. So it is very, very important to understand that if the patient is can afford the glasses, definitely you can give him as a primary therapy. And if patient is skeptical, you can at least tell him that you can start using low concentration atropine, and if it is needed, we will add on the glasses as secondary therapy. Indications pre-myopia, mainly because not that we don't use atropine for pre-myopia, but sometimes when you are using the drops, and we found it in our own study that when you tell the patient to use a drop for a disease which is at this point of time not really existing, they are little hesitant. But when you tell them that these glasses are there, and you can use a zero power or a minus 0.25 glass or a minus 0.5 glass at a young age. So if the child is 5 years and was hemetropic, came back to you after 6 to 8 months, now is going towards minus 0.5, such patients, yes, you can tell them that the kid is young, he may not let you put drops, or if you are afraid and no, you don't want to put drops, you can start glasses. Very young kids, sometimes you are also afraid that atropine, being atropine, may have side effects, although at least in our clinical work we did not find that atropine had huge or any side effects. So peripheral refraction is difficult, and you have to establish a cause for progression, that is very much there. But for peripheral refraction, to be honest, even if patients or children who do not show peripheral hyperopic defocus also respond to peripheral defocus lenses. So not all patients, and I will show you that in our data, which is very different from the Western countries data, we did not find that all patients, and there was, if you see the mean and standard deviation, the difference of standard deviation was quite a lot. In fact, similar findings have been seen in Indian population by Pawan Varkicharla, their group, in where they have actually found that there's a nasal and temporal asymmetry, with one part showing myopic hyperopic defocus and other part showing myopic where other parts showing peripheral myopic defocus. And Dr. Jyoti Matredia and the group, they found that uh, almost, I think, I don't remember exactly, but around 30 to 40% did not have any peripheral hyperopic defocus. And and the studies do suggest that peripheral hyperopic defocus, as a that is what we are treating with peripheral myopic, creating peripheral myopic defocus is only secondary to patient having an actual peripheral hyperopic defocus, and without having a defocus, what exactly we are treating. But they do work even in patients who do not have peripheral hyperopic defocus. So that is surprising. Now the second part is whether spectacles can be used as a secondary therapy, and I will be taking it up in my next talk on combination therapies. But yes, it can be either an add-on to the existing therapy, or if the patient is intolerant to atropine or intolerant to ortho-K lenses, it can be used as a replacement therapy. So yes, glasses can be added with the already going on treatment therapy, or they can be switched over to glasses if that particular therapy is not being used. These are some of the references which we will be talking about in the next class on combination therapy, about adding defocus lenses with low level red light, adding defocus to atropine, comparing ortho-K with defocus with atropine, because ortho-K and defocus work on the same principle. So what are this we have already covered in first two talks, and whether you can use atropine and glasses, whether it is safe to use them together. This is a good article which was published in 2022, where Kama et al. Suggested that DIMS can be easily used as a combination therapy for myopia, and we did our own work. Now there are multiple studies on this, and we will talk about it in the combination therapy class. And we did peripheral refractions in patients, on these patients, 10 patients which we used, and we found that at 22 degrees temporal and nasal, if you see the standard deviation, it is a huge standard deviation. And in some of the patients we actually did not find any hyperopic defocus, despite these being non-responders, and still they responded with DIMS. So not all patients who have peripheral uh, not all patients who have peripheral myopic defocus, uh, they also do respond to DIMS, despite the fact that they are actually a solution to peripheral hyperopic defocus. So that is what was the point that I was trying to make when I was talking about 22-degree nasal and temporal. You see the standard deviation is huge, and this was the refraction when we did on our peripheral refractive aid that we have devised. This particular device, I have shown you how to fix it, and we are currently into production, and this will be sent to all the fellows and all the delegates who are participating in this particular myopia control classes. Once they are formed, they will be couriered to your place, and you can also suggest what improvement we can do, and you can also suggest how much how much number you are getting. That way we can all club make a data of what actually is the Indian population. From multi centers we can find out what is the peripheral refraction that we are having in our country. Now, this is something which came up a few years back, not yet approved or not yet launched in India, about diffusion optics technology. And so as I was saying, that there's a difference between when a central cone is when a central cone has light more than the peripheral cones, and this is what activates the bipolar cells. And most of our modern environment, artificial contrast signals, there is overstimulation of retina, there is increased bipolar cell activity. This is the on bipolar cell which is activated, and that causes increased axial elongation, which causes the myopic progression. So what DOTS has is that it has artificial contrast activity, which is currently being used in the screens, which is causing overstimulation. Once we add diffusion optics technology, they have a central 5 millimeter aperture, and this rest of the place is the treatment zone. So what they are doing is they are diffusing the light, and it mimics more natural contrast, and it lowers the signal. So once it lowers the signals to the cones that are surrounding the central cone, it offs the bipolar cell. Once the off bipolar cell is stimulated, the signals for eye growth go down, and then there is less axial growth, which slows down the myopia progression. So dot lenses do produce good visual acuity. This is as per the paper, especially I have just touched upon the Cyprus trial that they have done, which was published in BMC Open Ophthalmology. And so what they are doing is they're trying to lower the contrast slightly. That is number one, and uniformly. Basically, what they're doing is they're reducing the amount of light that is coming, but they're doing it uniformly, so it doesn't hinder as such, it doesn't hinder the visual acuity. So what it holds is that this particular axial length, axial growth, is being driven by the activity in contrast pathways, which are produced by combination of signaling in the contrast pathways. Now what they are saying is that this all is being caused by genetic mutations and exposure to myopic genic stimuli. So what holds is that it through this diffusion technology, it is reducing the contrast, but it is causing it uniformly. Whereas if you see the current devices, the current artificial devices, they have very high illumination, and they do stimulate the peripheral cones more than the central cone, which stimulates the bipolar on cell, which stimulates the growth. So this is the theory behind dots. These glasses are not dots is diffusion optics technology, and this is not currently available in the country, but it may come soon, and we should be knowing about it. So yes, at this point of time, what is thought is that glasses are a useful adjunct in treatment. Of course, cost is a very important issue. At this point of time, it is not really a great first line of treatment, but yes, at least in some of the patients where we feel that the children would not be very cooperative, or if we feel that compliance would be a serious issue, what we feel is that you can even use it as a first line of treatment. We have our own data, and we do feel that glasses are a wonderful way of slowing down the progression, but we all can join together, create more data to find out whether there are any problems or not. An important point is that there is hardly any rebound compared to atropine. Once you stop using glasses, there's a very minimal rebound or no rebound which occurs with glasses compared to ortho-K or compared to atropine, where the rebound is also there by at least 0.5 diopters. So that is regarding glasses. Some few important points are that what is still not known. Despite all these things, we have talked about peripheral refraction, but at the same time, I did discuss that not all patients who are peripheral, who do not have peripheral hyperopia, still progress, and they do respond to these particular peripheral defocus lenses. So what is not known truly is how much is the sensitivity to blur. See, we all know that as you go in periphery, your sensitivity to blur itself decreases. So you would need more amount of defocus. How much sensitivity you need in the periphery to detect an actual blur. So whether this is true, because Once you go from center to fovea, if you go large distances like almost 20 to 40 degrees, you would need a very large blur. So you would need a very large hyperopic difference. A little amount of hyperopic difference will not be even detectable. That is the whole point. Now we are still inconclusive what is the optimum level of blur which can really cause the or influence the eye growth. Because if, see, I already said that if there is a difference of more than zero point 0.5 or 0.75, that is also significant at this point of time. That is also understood. But whether it is right or not, we don't know. Because what is the optimum level of blur that can induce eye growth? Whether even a point, you need a 1 diopter of blur, and that particular blur which you are having of 1 diopter in the periphery should be a detectable blur, because in periphery already your sensitivity to blur is reduced. And what level of defocus and what level of retinal eccentricity might influence foveal refraction. So some of the literature that I saw, this particular article on a mini review, they believe, this was published in 2023, and they do believe that the target area should be at least 20 to 40 degrees from the central visual axis. That is like a lot in periphery. And regardless of the lens type, another point that they did argue was that regardless of the lens type, one that corrects a higher amount of central myopia. If the lens thickness increases, or even the curvature is more, even if you take, suppose if you take a higher refractive index, the amount of central myopia will definitely affect the peripheral refraction, because it will result in a higher hyperopic peripheral shift. So once you are giving glasses to correct the central part of the myopia, see, you have a patient who has -1 versus you have a patient who has -6. Now both of them would receive their corrective glasses, but the glass which is -6 will induce a higher peripheral shift, higher hyperopic peripheral shift compared to a low powered lens. This is obviously there. Now with this, they also suggested that a high powered lens would induce a higher hyperopic peripheral shift, and would therefore be very, very important that it will induce a higher progression. It will induce a higher progression in children. Now, this is the article which we are going to discuss, which has changed the whole point of what is the peripheral level. Now, the peripheral level, according to this particular article, is only 6 to 10 degrees. Whereas in the previous article published in 2023, we found that the peripheral blur should be at the level of 20 to 40 degrees. And this particular article, what they did was, they tried to, they have used a machine, and we will discuss it with Dr. Minas, where they actually made 4 patches, and then they compared them, and in the conclusion they say that it is 6 to 10 degrees, which is should be considered for the treatment protocol. So that also is there. So this was regarding peripheral refraction, effect of peripheral refraction, and what are current spectacle options for myopia. We will discuss about the last article in our live meeting. So thank you so much.